Hi, my name's Jennifer Peterson, and this is my report for my Churchill Fellowship in Narrative Medicine. I conducted my placement during October and November 2023, and during that time, I was able to travel to the United States to 3 different centres to learn more about narrative medicine. My fellowship took place under the new sub-theme of palliative and end-of-life care, and because of my clinical work, I have a particular interest in neonatal, palliative and end-of-life care. And so the purpose of the fellowship was for me to travel and to join the 3 different centres, learn more about narrative medicine, and to try and distill what I'd learned back into a training programme around neonatal, palliative and end-of-life care. So, before I start explaining what narrative medicine is, it's probably helpful to give you a little bit of background about who I am and how I came to have an interest in narrative medicine. I am a neonatal subspecialty doctor, and so by that I mean I'm a practicing doctor who works in a tertiary neonatal unit dealing with very sick preterm and term babies who have a wide variety of problems, from medical issues through to surgical issues through to neurosurgical issues. I have been working in paediatrics for the last 10 years and specifically in neonates for the last 5 or 6 years, and I'm about 12 months off becoming a neonatal consultant myself. During my training, I've worked as a simulation fellow, providing training to healthcare professionals who work in maternity and neonatal medicine about how to deal with a wide variety of neonatal emergencies, both clinical emergencies that happen within the intensive care unit and also emergencies that can happen at the point of delivery. And through that, I became aware of the need for us not only to practice training around emergencies that we may encounter, but also to be able to recognise and respond effectively to when the treatments aren't working and when we feel we may have reached the limit of what's possible or what's appropriate for the baby, and where we need to start thinking about introducing palliative care principles or even end-of-life care principles. And that neonatal bereavement is incredibly stressful and emotional, obviously for the family themselves, but also for the staff that are attempting to provide that care. A neonatal death, it feels very unnatural because it's happening right at the beginning of somebody's life, and it can be difficult for staff and families to have the language or the emotional skills to be able to deal with that type of death because it is such a unique type of bereavement. So staff feel very nervous about encountering this type of care, and they can sometimes not know what the best thing to do is in terms of communication or how to provide that care around the family. They know they want to get it right, and they know that they want to be able to support the family and say the right thing at the right time and also have the knowledge to underlie that. But you don't want to be practicing these skills the first time on a real baby and a real family. So we designed several simulations to try and put staff in a position where they could practice their palliative and end-of-life care, communication and practical skills before they have to encounter it in real life. And those types of simulation have been really popular. I've also, during my clinical training, been able to work as a research fellow, and I moved into that position following on from the simulation fellow role, where I think I lent more into my interest in how we communicate with families and how we share information with families, and the practical and ethical and knowledge issues that can provide. So what we communicate, how we communicate, and how we gain the family's perspective on making decisions about the care of their baby. And that's led me to pursue a PhD that I'm completing at the moment in the communication and information sharing between professionals and parents that are facing peri-viable delivery. So birth at sort of 22 to 24 weeks gestation, which is about halfway through a pregnancy. So extremely, extremely early. And through all these experiences and my work in neonatal medicine, there was this emerging theme of my interest in the story of the family, the story of the infant, and really how we can best interact with and build on that as health professionals, so that whatever the care is that we're providing to the baby, and whatever support we're providing to the family, we're doing it using language and presenting information in a way that's best matched to that family for them to be able to make the best decisions they can about the care and the journey for their baby. So the more that I was researching communication styles and information sharing approaches between not only just professionals and patients, but also healthcare professionals and families, and between healthcare professionals themselves, I was finding the phrase narrative medicine was coming up more and more. And the more that I learned about it, the more that I thought, yeah, this is the type of medicine that I want to be able to practice, and a type of approach that would be incredibly useful in a palliative and end-of-life care setting. So that brings me to what on earth is narrative medicine? And I think that narrative medicine can sort of best be described as an approach and a toolkit that clinicians can use to become aware of and meaningfully incorporate the patient and the family's story into decisions around then an individualized approach to their management going forward. And narrative-based medicine can kind of be thought of as the needed counterbalance to evidence-based medicine. So evidence-based medicine, or EBM, is really important in modern healthcare, and we absolutely do need it. So narrative is not competing with evidence-based medicine, but it is enhancing it. So the evidence-based medicine, which is taught in up and down medical schools across the country, is an approach to medicine where treatments, healthcare plans are evaluated and statistically analysed to see what the best treatment is for a variety of conditions, and to evaluate if one medication is more effective than another, and also to evaluate safety data on treatments and medications. So evidence-based medicine is really important and absolutely needed to practice safely. However, because it comes from a research background and because statistical analysis is so important in evidence-based medicine, you are always going to be evaluating the treatment or the medication in question across a cohort or across a population. And therefore, there's no or little accountability for all the individual factors that will then apply when you're trying to take the results from the research or from that evidence-based medicine and apply them to the individual patient that's sat in front of you on any given day. Whilst evidence-based medicine and the research protocols that go on do try and take into account certain confounding factors in a lot of well-conducted randomised control trials, for example, they won't ever be able to completely match the research cohort to the individual person sat in front of you. And so it's the role of the clinician to be able to take the results from evidence-based medicine and integrate them into a management plan for their individual patient that they are seeing in their clinic or in their normal practice. And whilst a lot of medical schools and training programs will train clinicians in the skills to be able to interpret the evidence-based medicine data, they rarely, or they have less focus on the process for the clinician being able to then work with the individual patient and share that information effectively and listen and incorporate the view of the patient into their individualized management plan. And that's where narrative-based medicine comes in. And I think that's it's that counterbalance to the evidence base. And by having them both together, you can really improve the care that you're providing to the patient. Another definition that's been given for narrative medicine is that it is medicine that's practiced with the skills of recognising, absorbing, interpreting, and being moved by the stories of illness. And this was a definition that was given by Rita Sharon, who is sort of the founder of a narrative medicine approach. She kind of coined this term and this field back in 2001, and has been encouraging clinicians to practice using this approach since then. She is really interesting in that she was a practicing clinician and then developed this interest in story and the role of narrative within the interaction between professional and patient, and so went on to do a master's in English literature, and that led her to become much more aware of the structure of story and the structure of how patients understand and bring forward their own unique story into consultations. And that this is important because we need clinicians to be sort of narratively competent, so to be able to work with story and understand story and have an appreciation for why the story is being told in the way that it is. And that's something that's not touched on at all in like traditional medical training. More usually in more traditional training, it's encouraged for the clinician to, yes, listen to the patient and allow the patient to say what they need to say about their condition, but this is often done in quite a superficial way. So even though in a lot of traditional medical training models, the medical students will be encouraged to ask open questions at the beginning and then narrow down to closed questions toward the end, they will often end up interrupting patients in when they actually go out into the world of clinical medicine. So although in training we're told that the history is really important and the history that the patient gives you about their presenting complaint needs to be allowed some space and allow the patient to tell that story, what studies have shown is that actually in reality, in clinical practice, because staff feel very stretched and busy, staff will interrupt patients on average every sort of 6 to 8 seconds whilst they are trying to tell their story. And so currently in most of medicine, there is this disconnect between, in theory, being told that the story is important, but actually the staff haven't got the skills to properly work with that story. And that's one of the things that narrative-based medicine hopes to address, that by teaching clinical staff the importance of these skills of narrative competence and how to work with stories, that they will allow the patient more time to fully explain themselves and to work out the reason behind why they're presenting their symptoms the way that they are, rather than interrupting them and cutting them off. And a lot of the kickback against narrative medicine is that sounds like it's going to take a longer time for the initial clerking or the doctor to have to spend more time with the person in order to elicit this whole story. But actually, again, in the research that's been done in adult medicine and also pediatrics, it's been shown that by allowing the person to express their story in the format and the structure that they choose to, actually the clinician can pick up on a lot of additional information, and therefore the management plan is better formulated. The patient has a better understanding of why the management plan is the way that it is. The adherence therefore is better to that management plan, and the outcome is improved, and the consultation process overall will actually be shortened rather than elongated. So there are a lot of potential advantages to working with stories using these skills of narrative competence. And there aren't only advantages for the patients and the families, but rather a narrative medicine based approach also has advantages for healthcare professionals who are practicing as well. And this is related to the fact that the narrative based approach, in responding to and recognizing those individual stories and incorporating them into plans going forward, there adds an additional connection to the patient and a connection to the family that you're working with, and this has been shown to improve sort of healthcare professionals' fulfillment in their role and ability to feel that they are doing a good job in terms of the care that they are providing, because they're better matching the care that they're giving to the person in front of them, and they're establishing a much deeper level of rapport with the families, and that does impact the level of satisfaction that staff can have within their role. Additionally, in the fields of particularly neonatal and paediatric palliative care, these are exceptionally difficult areas to be working in, where there's a huge emotional burden, but also where there are very difficult life and death decisions to be made, and really difficult and deep conversations to be had about things like quality of life versus quantity of life, and everybody is going to have their own unique take on this, both the professional and each member of the family as well. And so when you're trying to provide this type of care, there are often going to be circumstances where your own personal ethical compass doesn't align necessarily with the family's ethical stance on a particular issue. And this has the potential to lead to a moral distress burden about providing palliative and end-of-life care to children, or about providing care for the continuation of intensive care for children in different circumstances. And this increased moral distress burden and emotional burden for staff can lead to staff experiencing numbness, disconnectedness from their work, low satisfaction, and also feelings that they are being asked to provide care to children that is cruel or prolonging their suffering. And that overall can lead to staff developing depression, anxiety, and high rates of burnout. However, if you have training in narrative-based medicine and a culture of narrative-based medicine within the place that you work, then these techniques are able to mitigate against those negative potential risks. So by practicing narrative-based medicine, staff are trained, as we've said, to attune to the story of that individual family, and to therefore have that deeper level of rapport, and that will allow for a deeper conversation to happen around risk, around the ethical concerns, around all of the potential treatment options. And that mutual understanding of the story from the family's perspective, but also the story from the staff's perspective, can mean that both parties don't end up getting entrenched in their own personal view on the narrative, and so it kind of reduces that conflict, because there's better information sharing between parents and professionals, and each side is able to understand the other's perspective better. And so usually there's a way to therefore forge a management plan that both parties are comfortable with, and that will ensure better care for the baby, better support for the family, but also reduce down those risks of moral distress burden and burnout and depression amongst the healthcare professionals as well. And narrative-based medicine can also have a role in helping staff be able to process their own emotions after the experience of going through a palliative or end-of-life care process with a family. Hearing other people's stories is a gift, but also can have an individual emotional burden on the staff member. So even in cases where there hasn't been any conflict between or potential conflict or potential ethical dilemma between professional and parent, the simple process of witnessing these bereavement cases and witnessing the distress for the baby and for the family will have a distress burden for the staff member as well. And so by using narrative medicine techniques, the unit or the hospital can create a culture where people are able to interpret their own emotional response to situations, and have forums where these stories can be shared between healthcare professionals. And again, that has been shown to reduce anxiety, depression and stress amongst staff and professionals, and make people feel that they are kind of honouring the story that has been given to them from that family who's gone through that bereavement process. Now, prior to undertaking this fellowship and developing my skills with narrative-based medicine, I had worked as the simulation fellow, as I've said, and through that work I designed several simulation scenarios that focused on neonatal, palliative and end-of-life care. And these simulations were designed to allow staff to practice the practical elements of providing palliative and end-of-life care simulation, so increasing knowledge and giving them a safe space that they could implement these skills, using actors to play the role of parents, and high fidelity mannequins to be used to practice skills on a simulated baby. Now, these simulations were really popular and staff found them really valuable, but the focus of each of the simulations was much more around the kind of practical elements of this type of sim. So things like rationalization of medication, rationalization of monitoring, the physical process of preparing and nicely moving a baby from a clinical area through to, say, a specific bereavement room, to allow the family to spend time with the baby in a quieter space rather than a loud intensive care room. And again, whilst these skills are really important, what I realised that the course was lacking was a focus on protecting and enhancing the story of the baby and the story of the family unit within this type of care. And that's what I wanted to develop my interest in narrative medicine, so that I could better inform this training course. And I think this is really important to think about in the context specifically of neonatal and paediatric palliative and end-of-life care. This is a very, very unique type of bereavement care, where in other walks of life and other walks of medicine, we have an established language and an established grieving practices that we're all, participating and we're all aware of. So for almost regardless of your geography, your culture, your community, your religion, the traditional kind of grieving practices will all involve an element of people gathering, sharing stories about the person that's passed, and sharing that language about that person, so that their memory is shared amongst the group, and people are able to reminisce about them. And in the context of an elderly person who's at the end of their life and has lived a long life, that feels a much more intuitive, comfortable experience for everybody involved. It can be very difficult when the death is of a baby or a child, because generally we lack the language to be able to talk about these things easily. It feels unnatural and it feels very difficult, and that it applies both for parents, for the family, for the wider community, and also initially for healthcare professionals. However, the effect of that can mean that parents often feel very isolated, particularly in the depths of their grief. And therefore, we need healthcare professionals who are well trained in being able to work with the story of that baby and that family, and be able to give back language so that the parents have got the words and have got the memories and the language that they need to be able to speak about their baby within their wider family and their wider community, when they are able to, so that the memory of that baby is kept present and involved in their family, going forward into the future. Professionals therefore need to be equipped with skills to naturally be able to elicit the family's sort of shared story and shared viewpoint on different issues, so that they are able to individually tailor the type of memory making that we do with that family. So in neonatal palliative care, there are lots of techniques that we can use for the family to be able to create special memories with the baby throughout the process of palliation or throughout the end-of-life care process. So, for example, things like bathing the baby, reading to the baby, bringing in the wider family, taking photos with the baby, potentially where it's appropriate, the baby visiting the roof garden with the family, or siblings coming in and having time where they read a book to their baby brother or sister. And all of these experiences can then create gorgeous memories that the family have got that are very, very precious during the grief process moving forward. However, what we don't want staff to be doing is just offering all of these options as a sort of overwhelming list to the family, who are already going through a very challenging time as they are navigating their own grief and reactions to the process of the palliative care or end-of-life care situation that they find themselves in. So what we need staff to be able to do is have those skills of narrative competence, which they can then apply, so that as they are then able to discuss memory making and family involvement in a way that's more natural, and in a way that means that they then craft the sort of narrative with the family going forward, so that it's individualised to that family. And to be able to do that effectively, we need staff to be able to navigate their own internal response and reaction to a few key areas that are particularly relevant to palliative and end-of-life care. Through the narrative medicine training that I have had through this Churchill Fellowship, I've become aware that they're really the main themes that are present in this sphere of neonatal care are professionals being able to cope with, interpret, and manage their own sort of professional grief. And this is something that really isn't touched upon widely in paediatrics, and staff aren't really given the necessary skills to be able to cope with this professional grief burden. They also need to be able to cope with the experience of encountering significant uncertainty. And this is again something that is very under recognised and under taught in medical and healthcare professional training. Uncertainty intrinsically is present across all walks and streams of medicine, but particularly is going to be present in sort of frontier areas such as neonatology. And yet, in most medical training models and healthcare professional training models, we see that staff are raised in an environment where there is a right answer. So they go through exam-based training where they have to select the right answer from the list. They have to be able to give the right answer in a Viva style or an OSCE style assessment. And this trains people to think that there is always a right answer, and that crucially there is also always a wrong answer. And it presents options almost as this perpetual sort of dichotomy of right and wrong. Whereas then when they get into clinical medicine and the reality of working in clinical medicine, they find that actually everything is not black and white, that there is a huge grey scale in terms of the decisions that we make and the ability to individualise treatment. And they encounter this huge burden of uncertainty, which is never more present than in palliative and end-of-life care. And so we need ways of equipping staff to be able to cope with that uncertainty, to understand it, to sit with it, to get comfortable with it, so that they can then better navigate it with the family and come to the best management option with that family. We also need to be equipping them with skills via, I believe, a narrative medicine approach to be able to create a culture of compassion within whichever unit they're working on. And this is so important because in order to process your own grief, cope with that uncertainty, and provide high quality care to the family, you do need to be able to preserve your own reserves of compassion, both for yourself, for your other professionals, and also for the infant and the family at the centre of everything. However, what we're seeing in an increasing number of high-profile maternity reviews, such as the Ockenden review, is that there is a real depletion of compassion within healthcare professionals operating within maternity and perinatal care. This isn't because the individual people that want to work in maternity are, not compassionate people. Indeed, the opposite's true. There are so many, inspirational, highly motivated people who care deeply about the individual patients that they are trying to treat, but rather that we are increasingly as professionals having to work in an environment that is incredibly overstretched, incredibly understaffed, with more and more expectation of being able to provide specialist care, and nowhere near enough staff or facilities to actually be able to action that. And that creates a conflict between the care that you want to provide and the care that you are able to provide, and means that people are very overstretched, and that will all reduce down the amount of sort of compassion that you've got available in your reserve, and mean that people are running on empty constantly. And therefore you get instances where care is not being delivered in a compassionate way because people are beyond stretched and experiencing significant burnout, which isn't good for professionals and isn't good for the patients obviously either. One of the factors that can contribute to this is the lack of clear or sort of consistent narrative throughout the care of a patient. So because systems are quite fragmented at present, it can be really difficult for the story of that patient to clearly carry through their care. And whenever that story is fractured, it becomes more difficult to view that person as an individual with their own individual priorities. And again, that can unconsciously serve to sort of dehumanize and make them not an individual but more a task on a sheet that needs to be completed. And again, this is obviously not the correct way to be providing healthcare. Therefore, there is a real role for a narrative-based approach to be infused back into maternity care through training and also through regular training and review sessions for staff. Again, there is research to show that narrative-based medicine training sessions, both for medical students and also for clinicians and other healthcare professionals, can increase the skills of empathy, increase the skills of listening, increase that ability to create a rapport with the individual patient, and all of that will preserve the story of that individual patient, and that does seemingly translate into improved care for the patient, but also in a refueling and a revitalising of the empathy and compassion that the staff member has as well. And I think that therefore links really nicely with this action point from the recent Ockenden review into maternity care. So this review was released in 2022, and as an immediate and essential action point number 7, there was a very clear reference to this need for compassionate care, and that staff need to be working in a place that supports their emotional and psychological safety, both at an individual level and a team level, with this recognition that well-supported teams are much better able to deliver kind and compassionate care. And so there seems to be a really good need for and drive for but more deliberate integration of narrative medicine training into maternity and perinatal staff training, and that therefore it would be really useful to design specific narrative medicine based sessions for healthcare professionals around these themes of dealing with professional grief, coping with uncertainty, and that will hopefully increase the reserves of compassion that staff members have and create a much better culture of compassion that will be a nicer place for staff, nicer and safer place for staff and patients to be experiencing healthcare in. So hopefully I've shown you that there is a real need for a narrative-based medicine approach within perinatal and maternity care, and particularly within neonatal palliative and end-of-life care training. If you're wanting to learn more about narrative medicine, I suppose the next question is how can you start doing that and where to start? It can be quite overwhelming at first because it is a very different way to practice medicine and there are so many different permeations of it. I started by doing some background Googling and some reading of the plethora of journal articles that are out there related to narrative medicine. And because there is so much research out there about it now, it's quite easy to also have a look at specifically narrative-based medicine and paediatrics, and have a look at the literature that's available that way. There are also lots of pre-recorded YouTube lectures that are available for free on the internet, and these can be accessed by simply searching narrative medicine or picking one of the more prominent narrative-based medicine practitioners, such as, for example, Rita Sharon, who's got lots of narrative-based medicine lectures that are recorded and, as I say, freely available on YouTube for you to have a look at. After I'd done that, I felt like that narrative medicine was very much what I was looking for and something that I thought was going to be really valuable to the way that I practiced and hopefully could be integrated into the palliative and end-of-life care sim course that I was running. I therefore wanted to get more in-depth experience of really what it looked like in real life and how you could put on narrative medicine training sessions for professionals. And so I self-funded to attend a narrative medicine 3-day workshop, which was run at Columbia University in New York last April in 2023. This was fascinating because they did a combination of lectures, the evidence base, and also put you into small group workshops which worked through a variety of narrative medicine techniques where you were told a little bit about the facilitation, but you were also very much a participant in those sessions. So you got to experience what it was like to take part and contribute to a narrative medicine session. And that was really interesting. that all led me to have just increased my passion and enthusiasm for narrative medicine. And so when I got back, I was really, really keen to be able to become a person that could facilitate this type of medical education. And I knew that I really wanted to have access and experience of live narrative medicine sessions and to develop the skills so that I could design my own and run my own in the future. So that's then what led me to set up my Churchill Fellowship in the way that I did, where I was able to travel to 3 different centres within the US to develop my facilitator training skills and also to observe and contribute to live narrative medicine sessions. And the experience was incredibly inspirational, and I just loved every minute that I was out there. It was an amazing, amazing experience. I decided to go to Portland in Oregon first because this is where the Northwest Narrative Medicine Collaborative was set up and runs. And this is a collaborative that I shall tell you more about in the next few slides. But they are a large organisation that provide really high quality facilitator training to equip people to be able to design and deliver their own narrative medicine sessions. I was then also able to travel to New York to attend a live storytelling event run by a narrative medicine group called the Nocturnists, which again was an amazing experience. And then thirdly, I travelled to Houston, Texas to attend a placement with a paediatric palliative and also PICU teams who have a really well-established programme of narrative medicine sessions that they run with their palliative care and PICU residents and interns. And this was an excellent placement to run on from the facilitator training that I'd had in Portland, and then to take that training and be able to see the sessions run live with real practitioners in the centre in Texas. So the first stop on my fellowship was Portland, Oregon for the Northwest Narrative Medicine Collaborative Facilitator Training course, which was taking place over 3 weeks from mid-October to the beginning of November 2003. I'd never been to Portland, and I went on the fellowship on my own, and so as I set off I was quite apprehensive about going to a completely new state and a new city that I had very little knowledge about other than it was where the Northwest Narrative Medicine Collaborative was taking place. Portland, however, was a complete surprise and a real hidden gem. It wasn't somewhere that I had previously considered travelling to, but it is definitely somewhere that I am really sure that I will return and want to spend more time exploring, because it is just such a beautiful place and there is so much history there as well. As well as it being a modern city with all the, services and amenities and things that you could possibly want, and some excellent coffee and really wonderful range of different foods, it also has all of this natural beauty around it in the surrounding coasts and mountains that are prevalent across the whole of the state. The photo in the middle there with the red trees is from Washington State Park, which is right in the city of Portland, and is such an incredible space. I think it's something like 142 acres of parkland that is free to go and have a wander around, and contains the world famous Japanese botanical gardens that are situated within it. And it was also the place that we were able to spend some time travelling to the coast and into the mountains on the days off from the facilitator training. And it was a really perfect place to undertake this facilitator training, because not only were the people from the collaborative really inspiring and welcoming, but being surrounded by so much natural beauty just provided a really nice reflective space to engage with the narrative medicine readings and materials, and to become aware of the impact of spending time in nature and spending time reflecting on your practice, and the kind of positive effects that can have on your idea development and your ability to think about how you want to take your practice going forward. So while I was there, I, as I say, undertook this 3-week training via the Northwest Narrative Medicine Collaborative to become a facilitator for narrative medicine sessions. The Collaborative is a really interesting organisation which was set up in 2018 by Elizabeth Lartey, who is a practicing clinician and who has developed her own skills in narrative medicine through the interactions that she had with her patients and patients' families, and through those interactions became aware of the role that art and humanities should be playing and the role story should be playing in the type of care that we provide. She's built up the Collaborative with other professionals and humanities and artists, people who've got an interest in story and literature, academics, researchers, patients and caregivers, so that the Collaborative has really become a multidisciplinary force that provide information, support and resources to people with an interest in narrative medicine. They have an online space which houses all of their training opportunities and also their narrative medicine resources. So this narrative medicine library is a really excellent digital library that is freely accessible to people that have joined the Collaborative, which again just involves sending in sort of your name and your email and getting added onto the Collaborative list. And then you've got full access to the resources that they have in there. They've got some really useful pre-recorded lectures about narrative medicine, as well as artworks, poetry, and readings that you may want to incorporate in your own narrative medicine sessions. They also have got links to other people within the Collaborative so that you can interact and engage with other Collaborative members, either synchronously or asynchronously, depending on geography and time zones. But it's a really welcoming space where people are very appreciative of the fact that this is not a commonly practiced type of medicine, and so there are going to be lots of beginners or people with an interest but that might be unsure of where to go next. And so the community within the Collaborative, as I say, is just very welcoming and supportive, which was really, really nice, especially for me as a beginner. They also run lots of training events, again with both synchronous and asynchronous options, and a combination of in-person and virtual training sessions as well, which is really nice. So it tries to minimise that time zone and geography barriers as much as possible. From a training point of view, they run lots of online workshops and webinars, but they also, I think once a year, run this narrative medicine facilitator training, which was this course that took place over a 3-week period, and again was such a worthwhile experience. There were access during the course to a variety of lectures and also small group sessions, and the opportunity to both be a participant in narrative medicine sessions and reflect on your own practice, and then also over the course to design and develop your own training sessions that you could then try out in your small groups and get feedback on, and then take forward with you into your future training practice. And throughout that whole 3-week journey, it was just an incredibly inspiring process. We were exposed to so many different types of stories, poems, reflective writing pieces from, again, a wide variety of writers. We were encouraged to do our own reflective writing sessions and think both about the themes that came up in those, and also the feeling of participating and how vulnerable and exposing that can be, and how that relates to that vulnerability that the patients will feel while sharing their story in a consultation, and also the vulnerability that will come up if we then are doing our own narrative medicine training sessions in the future for future participants. And the facilitator training really equipped us with the skills to be able to manage that vulnerability and manage that emotion within the narrative medicine sessions. We had a really interesting group of people that were within the facilitator training, and it was really unique because it was a real combo of healthcare professionals and also people working in other professions related to healthcare. So we had writers, we had artists, we had chaplains, we had teachers, we had caregivers, we had patients, and people with experience of their own healthcare as well as their professional role. And that really meant that the discussions that we were having were enriched by all of those different perspectives, rather than it purely being a group of healthcare professionals who would have had a much more similar level of background experience. So it was really insightful to have the views of people from kind of the other side of the creative process, so the writers and artists and academic researchers that were also present and contributing to the conversations that we had, and giving really useful perspectives on issues within healthcare and healthcare training. So that really enhanced the discussions that we were able to have. And as I say, it was just a very inspiring and welcoming group of people to be able to join. So over the course of the 3 weeks, we had an intense period of being exposed to a really wide range of narrative medicine techniques that ranged from kind of short training sessions that you could do within the confines of a clinical busy ward round, through to organised large group sessions that could be run on a pre-specified training day. We also looked at a range of techniques that would be appropriate to be used between the patient and the professional, and then techniques that might be more amenable to use within purely professional training sessions. And it was just so interesting to see the really wide variety of creative techniques that are out there and that are being utilised to improve everybody's clinical practice, and really integrate narrative medicine into a meaningful way into the clinical care that's being provided. We learnt about simple techniques such as the use of note cards, which can be used in different ways to inject a little bit of narrative medicine to handover or a clinical ward round. So, for example, using short extracts of a story or a patient account or a poem, either during a handover or at the end of a ward round, to get people to interact with that poem and give a few sort of short, sharp reflections on what the poem makes them think of in relation to a specific patient or a specific encounter that they've had during that ward round or clinic experience. You can also use things like parallel charting, where you would get students or junior doctors to consider not only just the medical information that is being written in the patient's kind of official medical notes, but rather to also encourage them to get into the practice of writing their own notes, almost to themselves, which, depending on the specifics, may or may not get shared with the patient in an appropriate manner. But for them to be having this parallel chart, which reflects more on the things that came up for them during the encounter with the patient, what they're feeling about the kind of wider context that the medicine has been practiced in, that the patient is living within, and their own kind of reaction to any uncertainty that came up within the consultation, or the emotional factors that came into the consultation, or moral dilemmas that maybe came up in the course of that care, and to be starting a kind of reflective log or journal where they are able to record that, think about it, potentially come back to it, so they can see the kind of evolution of their own thinking. There's certainly a lot of evidence, again, about the process of writing down your own thoughts and feelings as a tool and a technique to help you process them and to arrive at more nuanced conclusions through the act of doing that, rather than simply feeling the emotion and then pushing it to one side and having it express itself in a less productive way. We also learned about different techniques that can be employed to facilitate group sessions around pieces of art, story, and patient accounts, and how to set up those sessions so that the professionals are able to fully contribute to them without feeling overwhelmed or overly vulnerable. Techniques that can be used to ensure that people are made to feel comfortable about sharing their reflections or their thoughts and observations within a wider group, and also how to manage the psychological safety that is so important to running sessions like this. We had reflective writing sessions with a wide variety of people, including one workshop around writing difficult stories by a really inspiring memoirist, Melanie Brooks, who shared the process of her own experience writing her own story, and also giving us some, again, very practical tips about how to best support and elicit difficult stories from patients and professionals. We also learned about some more unusual types of narrative medicine that, again, could be really useful in our future narrative medicine training within our own centres. So things like VTS, which is a visual thinking strategy, and this is a very specific type of observation and getting people to practice the skills of observation using pieces of artwork. So looking at artwork, getting people to reflect and think about a series of 3 questions to improve their ability to observe and elicit detail from the scene in front of them. And this has been, again, shown in the research to improve their observational skills, and also then relate that back to the things that they're able to observe and act on in interactions with patients, and improve the care that way. We also had some really fascinating workshops with graphic medicine and this concept of zines as a way of sharing information. And we learned about the types of information that can be shared by graphic medicine, and how these can be used within training and education, both for medical students and also for healthcare professionals. And throughout the facilitator training, the emphasis was on using all of these different types of creative media to best engage your participants, so that they are able to focus on the wider elements that are not specifically clinical. So we're not worried about the interpretation of a specific blood gas, but rather we're trying to look at the larger themes in healthcare, things like coping with uncertainty and clinician grief. And that by using creative media as your third object to sort of stimulate that discussion, you remove the possibility that the people are going to get hung up on, the specifics of tiny details within a say fictional case history, and more that they're going to focus on those wider themes and interrogating their own reactions to them and perspectives on them, which is what you want from these types of sessions. It was also really wonderful to work with such a wide range of multidisciplinary professionals as well, to see a real range of different media being used, and to be put in touch with resource websites and materials that I wouldn't have come across in any other way. It really opens your eyes up to a whole humanities world that's out there, and that we can interact with and be welcomed into, so that we are bringing more of that art back into medicine, and making it more of that traditional collaboration between the arts and the sciences, and using different techniques and different media, so that we're encouraging a range of learners to be able to interact with the session. One of the things that I noticed about myself is that I've got much more of a comfortable interaction with like written words, so stories, and also the process of reflective writing. I found that really helpful myself, but I'm very comfortable with language, and really enjoyed doing things like English literature back at school, whereas obviously other learners are going to have different perspectives. So for me, through the facilitator training, I became aware that I would want to consciously make sure that I'm incorporating auditory materials such as different pieces of music, and comparing and contrasting those around different non-clinical medical themes, but also using more visual pieces like visual artwork, abstract artwork, to also try and elicit those wider conversations within my narrative medicine sessions. So as I said, Portland was just a really special place to undertake this facilitator training. Not only was the people that I met through the Northwest Narrative Medicine Collaborative very welcoming and incredibly supportive, but the city itself was also a great place to be encountering all of this natural beauty, and also a really creative space where the kind of art within daily life is prioritised. So through speaking to people who lived in Portland, they were telling me that the city itself, I was noticing that whatever street I walk down, everywhere that you look, you can constantly see all of the mountains kind of covered in trees in almost whichever direction you look in. And there's something really lovely about that as you're walking around then this man-made city. So the locals were saying that in the development of the city, people really did want to preserve the trees, and they didn't just want the city centre to kind of enlarge and take out more of the trees and the natural beauty around it. So they've set up this zone of urbanisation, which is a sort of city limits approach where the city centre could expand up to, but then no further than. And so that means that, as I say, whichever direction you look in, you're never far away from seeing the trees on the mountains that surround the city. And it just really makes you feel that the access to nature is very much present and is important to people that are living in Portland. They also have this lovely thing within the city, which I'm demonstrating in this photo, where there are loads of pieces of artwork and murals that are painted all over the city, and that they are funded through the city councils. So people who are resident and live within Portland, within the city itself, pay an additional tax every year, which is a fairly nominal amount. I think they said it was something like $30 a year, and that goes into a local artists fund, and through that fund different local artists get commissioned to do murals or statues or art installations around the city that then you can kind of walk past and all of the residents and visitors can benefit from, which is a really lovely, like, creative medium to just be witnessing around the city. So by the end of the 3 weeks in Portland, I had not only fallen in love with the state, but had also completed my facilitator training with the Collaborative, and had gained a real understanding of how to put together narrative medicine training sessions, how to access your resources to be used within those sessions, and how to manage the psychological safety whilst providing that type of training. I'd fleshed out a series of narrative medicine sessions that would apply to neonatal, palliative, and end of life care. And I was then in a place that I wanted to try and test those out in my placement in Houston, in Texas. I first, however, flew to New York because fortuitously at the end of the facilitator training, there was the weekend after, there was a live storytelling event being run by a narrative medicine storytelling group called the Nocturnists in New York. And this event was incredible to go to. It really brought to life the power of listening and reflecting on somebody's story, and also the importance of allowing that story space to be shared without any interruption. So The Nocturnists is a freely available podcast, available across a range of podcast platforms, and I'd encourage anybody that hasn't ever listened to an episode to go and have a little listen. They're really interesting and cover a wide range of non-clinical healthcare issues, and so are fascinating for both healthcare professionals and anybody not working in healthcare alike. The Nocturnist group was set up by a adult clinician who has now built up a team around her, and they run these unique live storytelling events around the country, are sort of centered around a particular theme. And so the theme of the one that I was able to attend was around the theme of taking care. So the way that it works is months prior, they put out a call for specifying the theme and asking people to come forward with their stories, and they get entries from a range of healthcare professionals, patients, caregivers, and then they select, I think it's about 6 to 8 of those people to then present at the live storytelling event. They do work with a storytelling coach prior to the event to practice the story, but it's very much the individual that is bringing their story and structuring it the way that they want to. And then on the during the live event, people gather and sit and listen to that story in its entirety in an uninterrupted way. And it's a very intense and reflective space when people are getting up and just having, as I say, an uninterrupted platform to share that story. What's interesting is that as you're listening to it, obviously you have lots of questions that are coming up in your mind, but by not having any avenue to interrupt or ask those questions, actually what you find is that over the arc of the story, those questions are all answered, and that simply by allowing that person the time to speak and give their story to you in its entirety, you will get the answers to virtually all of the questions that had popped up in your mind. And I think that's a really useful thing to have at the forefront of your mind when you're speaking to patients, families and parents within neonatal care. I think the process of listening both to the podcast and also attending the storytelling event live was that it really emphasises to you the gift that is receiving somebody else's story. And I think when you first hear that concept, it sounds quite woolly and quite vague, but there really is something special about being allowed to hear somebody's story. And I think, again, linking to some of the reflective writing sessions that we'd done during the narrative medicine facilitator training, this vulnerability that comes with putting your story out there was just really emphasised to me. I think working as a clinician where you are hearing people's stories constantly, it's sometimes easy to forget how vulnerable it feels to tell your own story. And so I think clinicians undergoing these narrative medicine sessions, having either reflective writing sessions or spaces where they can practice sharing their own stories, is important to sort of remind them of the preciousness of the gift that is sharing your story with somebody, and that it is a privilege to hear those stories and receive them and be allowed into that kind of inner narrative and inner thought process of somebody else, and that we shouldn't sort of lose that in the busyness of clinical practice. New York was also really wonderful because I had thought that I would be attending the storytelling event on my own, but through the Northwest Narrative Medicine Collaborative training, I was put in touch with some paediatric palliative specialists who practiced out of New York and who were also attending the same Nocturnist event. So it was a really wonderful opportunity to be able to meet up with them prior to the storytelling session, and to be able to hear about their own experiences with narrative medicine and how they've incorporated it within their clinical practice and within training that they provide at their centres. So that was a really lovely moment and a lovely example of how welcoming this space is and how passionate people are that are working within palliative and paediatric narrative medicine care. So following the storytelling event in New York, I was then able to fly out to Houston, Texas for the third and final placement of my fellowship. And here I was based at Texas Children's Hospital, which is in part shown on the photo in the middle. The Children's Hospital and the whole kind of medical district within Houston was absolutely vast compared to anything in the UK. Every building that you can see in the photo in the centre is part of the medical complex, and there were just skyscraper style buildings in almost every direction within the medical district. There is a huge presence of highly qualified and motivated individuals who are working within these incredible facilities, providing clinical care and also education and training, and there's a real emphasis on research facilities there as well. And I was very lucky to be able to join the paediatric palliative care and PICU teams, so that I was able to see how they've integrated narrative medicine throughout their programme. And they were also able to put me in touch with people at the local universities who allowed me to sit in on sessions that they were running with their medical students around narrative medicine and using narrative medicine within training curricula, which was fascinating and gave me some real insight into actually running these narrative medicine sessions with sort of a live audience, as it were. The other picture of the cowboy boots on the left of the screen was a photo of some artwork from my accommodation, which I just loved. This kind of pride in their city and their state and their history and heritage, and this combination of cowboy boots and then the theatre operating sort of blue overshoes over the top as a piece of artwork, just kind of showing that link between the practice of medicine, but also the fact that you don't have to lose your own individual identity within medicine, and that you can have sort of a creative outlet for any aspect of yourself within the work that you do. So while I was based at Texas Children's, as I say, I was able to see their narrative medicine program in action, and that involved attending the regular program of sessions that they run with their paediatric palliative professionals and also with their intensive care professionals. And I was able to participate and then have a go at running some group sessions using narrative medicine principles. So doing some close reading, close listening, and close reflection around artwork, short story extracts, and then kind of group reflective exercises. It was also really interesting to see how much having the narrative medicine sessions built into the programme had encouraged this sort of culture of reflective practice and considered practice, which was obviously then linked to the kind of high quality of care that they were able to provide within these teams. And also another angle was that they were able to have built up the narrative medicine curriculum not only within the kind of postgraduate curriculum that was being provided to residents and interns, but also through the medical student programs. And this was seen through a VTS or visual thinking strategy session that I was able to attend, which very much linked using artwork and interpretation of the artwork and observation of that piece, then through to your observational skills during clinic assessments. So improving your observational abilities within, say, developmental community paediatrics, where you're observing what the child does and crucially doesn't do, and how they interact with others to form your assessment. So really a very practical linking of the artwork observation to clinical practice, which was really interesting to see. We're also able to hear from the elective students who had developed their own narrative medicine ideas and student-led projects through, again, art, reflective writing and short stories, and linking some of those with systematic reviews. So looking at the evidence base for narrative medicine in different sectors and parts of medicine. And again, the kind of established links between the arts and humanities and ethics sectors of the universities, and then bringing those very closely into the training that was given to the medical students, so that medical students are being trained in a culture and an environment that already is showing them that the science of medicine should very much be linked with that art and humanities element of medicine as well, so that medicine is a reflection of both the art and the science, which it always historically was, and which hopefully increasingly will be incorporating into clinical practice more. They also ran some arts and resilience sessions with students, looking at a wider range of sort of societal factors, such as racism in medicine, the recent Supreme Court decisions such as Roe v. Wade and the impact that was having on clinical care that was being provided. And it was so fascinating to see the students really grappling with creating their own visual art pieces to represent the things that they were seeing around them, and just how powerful those pieces could be. So these were all medical students that participated in the session, and they were asked to have a think about a sort of wider area or wider theme within healthcare and provide a reflective piece according to that theme. And they could take it in any direction that they wanted to, but they were given some materials about the sort of importance of imagery and how to communicate through creating a simple message through the piece of artwork. And as I say, the creativity and power that came through in the pieces that they produced was amazing. Really, astute, clear messages being communicated through the artwork that they provided. Just showing that there is that sort of creative force within most healthcare professionals, and that it's nice for it to have an outlet and be used as a way of stimulating further discussion about some really difficult issues. I think sometimes things like speaking about wider themes in healthcare, things like the clinician grief, uncertainty in medicine, topics that are wide ranging and that make people feel really uncomfortable. If you try and raise that discussion directly, it can feel too much. It can feel quite overwhelming. It can easily become quite personal and feel like more of an attack than a discussion. And whereas in these sessions where the facilitators were stimulating discussion of the same topics but via the piece of art, it gave that distance that then allowed the students to go deeper into the reflection and reach more kind of meaningful conclusions and practical ways forward. So that was really nice to see that in action, and give you some practical takeaways for hopefully, again, how I can integrate those techniques in future narrative medicine sessions that I wish to run. While I was there, I also met and had loads of really interesting conversations with a variety of different multidisciplinary professionals that work within Texas Children's. Everybody was so welcoming and just really enthusiastic and passionate about what they were doing. And there was a really well-established sort of culture of care and compassion that came across. It was interesting to see some of the practices that were established within their unit alongside the narrative medicine sessions that I think really added to this kind of culture of compassion and support. So, for example, within the palliative care team, who obviously are all encountering continual, patient loss and clinician grief, they had a really nice practice of, during their multidisciplinary handover, which happened once a week, they would review any cases of patients that died, but from a holistic standpoint and from a sort of professional team standpoint. So in addition to all of the medical reviews and things that need to happen, they would also have the opportunity for everybody to have a candle, obviously an electronic one, because we don't want flames within a hospital that contains oxygen, but they had a reflective electronic candle each, and the people were able to come forward and share their own personal stories about interactions that they'd had with that child or with that family. And this was such a beautiful and cathartic process that felt very special to have witnessed, and I think was a really unique practice that I haven't seen anywhere else, but which felt like a really nice way of honouring the child, honouring their family, and honouring the story that you had been a part of. And so that's definitely something that I would be interested in trying to integrate into units that are working in the future. It was also interesting to meet with practitioners who were using other narrative medicine techniques that I hadn't come across before. So I was able to meet with professionals who were using techniques such as dignity therapy. And read a bit about the research of that being applied to paediatric medicine. So met with a practitioner called Jared Rebenstein, who has done some work around dignity therapy and paediatric end-of-life care. And this is where the patient, in this case the child themselves and the family, can work to produce a story of that child's life in their own words, to reflect their thoughts and opinions about their life, about their experiences, and their almost reflections or advice to their friends and family for after the event of their death. And this type of dignity therapy has been really well researched in adult medicine and been found to be quite helpful to the person who is going through the dying process, as well as providing a unique memory for the family afterwards. But it was really interesting to interact with some of the stories that had been created by paediatric patients and their families, and to see that there is potentially an exciting role for this to be used within paediatric end-of-life care too. The team were also really welcoming in including me in other events that were going on in the unit during the time that I was there. So, for example, there was Thanksgiving that was happening in the States in November, which I'd never participated in, obviously coming from the UK, but they did a Friendsgiving lunch on the unit, which was really fun to be part of and to try lots of different foods. I was also really privileged to be able to join the palliative care team in their ward rounds and to meet some of the patients and the families that they were working with. With the kind of narrative medicine based approach being so integrated within their team and their training, there was a real impact on the way that they were able to communicate with families and their ability to sit with difficult conversations and be able to appropriately react to difficult emotions or difficult conversational topics. And a lot of this came around to not avoiding the difficulty of what was being discussed, but to really lean into that in a very open way, to not be putting words into the mouths of the patients or the family or trying to second guess or preempt what they were going to say, but rather using calm, reflective statements in a well-timed and effective manner so that the parent or the patient was able to divulge more of what they were trying to say in their own words. And this meant that in a much quicker way, the consultation was able to go to kind of a deeper level and discuss more of the things that were important and pressing to the family, and identify what their goals were for the direction of treatment that we were going to be going down. And this was best done with, as I say, these well-timed and considered phrases. So simple statements like, you said X, tell me more about that, and then leaving it and allowing the parent to interact with that statement as they wish to. And although these things sound simple, it's actually very difficult to do in real life, and being able to know how to react and listen and interpret to the answers, it also takes a lot of skill and nuance. But certainly using these simple reflective phrases is again something that I can immediately carry back into my own practice, and something that I definitely will incorporate in the future training packages that I put together. To round off my placement, I was encouraged by my supervisors, Daniel Mahoney and Amanda Ruth, to run my own narrative medicine session within the paediatric palliative care team training hour. And this was really, really useful because it really brought together a lot of the techniques that I'd come across and seen through both the Portland facilitator training and then also my time during Texas Children's placement. So the session that I ran was around uncertainty in medicine, and used a piece of artwork that I had come across in the art museum in Houston itself, and some interpretation around different perspectives around how this abstract piece of art could be viewed. I then linked that with a poem written by a healthcare professional about an experience with uncertainty in medicine, and we discussed and did a group discussion around how uncomfortable that can be in clinical practice. And then I rounded out the session with some reflective writing and sharing, again around that theme of uncertainty. This was such a useful experience because it was the chance to practice delivering some training sessions to a group that were well versed in how narrative medicine sessions should be run. And so I was able to get some really good feedback from both the participants and then also my supervisors. And it was also a real good confidence boost for me to have the confidence that I did know how to run the sessions, and I would be able to run them when I got back to my own unit and incorporate them hopefully in the simulation training moving forward. So, what are my next steps going to be now that I've returned from my Churchill Fellowship? Well, the first place that I want to start is by completely restructuring the palliative and end-of-life care simulation package that we have in place at the moment. During my facilitator training and time at Texas Children's, I have developed more of my skills about the importance of and interaction of the professional with the story from the patient and the family. And what I want to do is to have a much more conscious patient narrative that runs throughout the course design of the simulation training that we provide. I've also been working with some parent feedback on end-of-life care, which I've integrated into the scenario content that I will now be providing on the future versions of the simulation training. And I've also restructured it so that we not only have a parent session within the training package, but also I've integrated time to run 2 narrative medicine sessions within the 2-day training. So one will focus on coping with uncertainty and the other will focus on professional grief, and they've been integrated on day 1 and day 2 of this 2-day training package. The other thing that I want to do now that I've returned to the UK is to try and disseminate more knowledge about narrative medicine and narrative medicine techniques throughout the neonatal and paediatric professional communities. It's not an area of medicine that receives a lot of attention in training or in professional neonatal and paediatric journals. And what I would like to do is to use the knowledge and contacts that I've formed in Portland and New York and Texas to write up a series of presentations and papers around how narrative medicine can be used within neonates and paediatrics. When I was in Portland, with the contacts that I was making there, I put together some abstracts for which was submitted and accepted for the International Medical Humanities Conference, which happened just this last weekend in March of 2024 in London. And I was able to attend in person and present my work around using narrative medicine communities of practice to build narrative competence for healthcare professionals, and why this was important to the quality of care that healthcare professionals can provide. This was a really interesting conference because it allowed me to get in contact with more people that work in medical humanities within the UK and establish some future UK-based contacts as well, which will hopefully also help in building my skills now that I'm back home. I have also put in some abstracts to be able to present work around using narrative structure and competency in terms of being able to address ethical issues within pre-birth conversations between professionals and parents who are experiencing a peri-viable or extremely preterm birth. And we are waiting to hear whether this abstract has been accepted for presentation at an international ethics and philosophy in medicine conference. Also, in collaboration with the team at Texas Children's, so Daniel Mahoney and Amanda Ruth, I'm hoping to work up 2 articles looking at giving an overview of how narrative medicine can be practically used for busy paediatricians and neonatologists, and also an article looking at the implications of appropriately using narrative and storytelling within the peri-viable decision-making conversation with parents. And these articles are being worked up currently. This whole process has been, again, a lovely example of how welcoming the teams were in all of the centres that I visited, and how actually, because of the times that we're working in, with everybody being much more used to using Zoom and Teams, it's actually quite easy to keep in touch with people and to continue working on projects even across geographical and time zone restrictions, which has been really nice to feel that I am still able to interact with the communities that were so supportive when I was doing the fellowship. Throughout my placements, it was working with the enthusiastic practitioners both at the Northwest Narrative Medicine Collaborative and also at Texas Children's that really showed me the importance of having a strong community around you when you're trying to develop and maintain your narrative medicine skills. Whilst interacting with people within those communities has been wonderful, there are obvious geographical and time zone restrictions from trying to continue participating in those live or synchronous group training sessions in the future, now that I'm back here on UK time. And what I'd like to do in the future is to work with a few people within the UK to think about maybe building up a similar collaborative or special interest group of neonatal and paediatric professionals with an interest in narrative medicine, to try and create that special interest group who could then work alongside other organisations such as the US-based Northwest Narrative Medicine Collaborative or the Columbia Narrative Medicine programs to run similar events and host similar training webinars and training days, but to do so on a time zone that is compatible with practitioners attending within the UK, as I think this would be a really useful future resource to develop the expertise and training within paediatric narrative medicine within the UK. So to conclude, I hope I've shown you how important story and the role of narrative is within healthcare, and particularly within neonatal, palliative and end-of-life care. Storytelling and working with narratives is a skill that may be more or less intuitive to different healthcare practitioners, but like any skill in medicine, it is a skill set that can be developed and improved, particularly through narrative medicine-based training. Narrative training needs to be incorporated into all aspects really of healthcare education, but particularly that of palliative and end-of-life care, and that's what I hope to carry forward following this fellowship in the development of my new revised narrative-informed simulation training sessions around neonatal, palliative and end-of-life care. In terms of the fellowship, I obviously want to say a huge thank you to the Churchill Foundation for selecting my project for funding and to carry forward. It's been an incredibly unique experience that I just would not have been able to have in any other way, and I'm so deeply grateful for you selecting my project and giving me the time to explore this interest and develop my skills in narrative medicine facilitation. To everybody that I met on my placements across Portland, New York and Texas Children's, you were all so welcoming and supportive of me, and I really appreciate you taking the time to share your experience and expertise with me. It's been a wonderful placement and I've enjoyed absolutely every second of it, and I can't wait to see where narrative medicine takes me in the future. So I'll finish with this quote on the slide from William Carlos Williams, who was both a physician and also a poet. And I think it just emphasises nicely how important and special sharing and hearing these stories are within healthcare. So he said, "Their story, yours and mine, is what we carry with us on this trip we take, and we owe it to each other to respect our stories and to learn from them." Thank you very much.